Good evening, class. Tonight we'll be going over chapters 18, 19, 20, and 21, which include postpartum physiologic changes, nursing care of the family in the postpartum period, transition to parenthood, and postpartum complications. Chapter 18, maternal physiologic changes. After birth period is the interval between birth and return of reproductive organs to their non-pregnant state. This is referred to as the puerperium or fourth stage of pregnancy. Traditionally, it lasts approximately 6 weeks, and although this varies among each woman. The uterus involution process is the return of the uterus to a non-pregnant state following birth. The progress occurs rapidly, and the fundus descends between 1 to 2 centimeters every 24 hours. 2 weeks after childbirth, the uterus is no longer palpable and returns to the non-pregnant state by 6 weeks postpartum. So when you're checking the fundus, you'll feel the fundus slightly above the umbilicus after delivery, and usually within 24 hours to 48 hours after birth, before the mother goes home, you may feel the fundus 1 to 2 finger breadths, possibly 3, below the umbilicus. So the subinvolution is the failure of the uterus to return to its non-pregnant state. Here is an idea of if the patient has a full bladder the day postpartum, her fundus will feel much higher than it should be. If the fundus is found displaced to the right, displaced to the left, have the patient get up, go to the restroom, pass her urine, come back, and then reassess where the fundus is. This is actually showing you the proper technique to assess the fundus. You'll place one hand lower on the abdomen, right above the pubic bone, kind of to hold the bottom of the uterus in place. You don't want to take your other hand and push on the top of the fundus to find out where it is and accidentally cause the uterus to be displaced. So you want to hold the uterus at the bottom, pretty much put your hand at the bottom. It'll be close to where a C-section scar is if your patient has had a C-section. Don't want to hold very firmly there when they've had a C-section, but kind of place your hand at the bottom, and then kind of cup your hand at the top where the fundus is so that you can tell how far the fundus is down. So the uterus contractions occur. After birth, hemostasis is achieved by compression of the intramyometrial blood vessels as uterine muscles contract. Hormone oxytocin is released from the pituitary gland, which strengthens and coordinates the uterine contractions. That is the reason that we use oxytocin, to help with augmenting labor. The uterus, a placental site. Lochia, post-birth, the uterine discharge. Lochia rubra is blood and some debris, and the duration lasts between 3 to 4 days. So this is going to be post-birth. Instead of bleeding, we call it lochia. Lochia post-birth, uterine discharge. Lochia serosa is old blood serum, leukocytes, and debris. This happens after that 3 to 4 days, up to 10 to 14 days. And Lochia alba is leukocytes and epithelial cells, mucus, serum, and bacteria. It continues for 2 to 6 weeks after birth. The cervix is soft immediately after birth, and during the next 12 to 18 hours, the cervix shortens, becomes firm, and regains its pre-pregnancy form. External os regains its pre-pregnancy appearance, and the cervical os is dilated to 10 centimeters during during labor, but gradually decreases to 1 centimeter at 1 week postpartum. Vagina and perineum. The introitus is edematous and erythematous. The episiotomy sites can take 2 to 3 weeks to heal, may take 4 to 6 weeks to heal completely. Hemorrhoids or any kind of anal viscosities are common and decrease within 6 weeks after childbirth. So after a patient has delivered, most likely if they've had any kind of stitches in their vagina or perineum area, or they have hemorrhoids, you would want to give them Miralax or Colace, Docosate to go home on, because you don't want them to be straining to have a bowel movement after they've delivered if they already have some other issues going on. The pelvic muscular support. The supportive tissues of the pelvic floor can be torn or stretched during birth, and it can require up to 6 months to regain tone. Kegel exercise are encouraged to help with healing. This will help with postpartum urine leakage as well. So Kegel exercises are very important to help with those muscles after childbirth. Placental hormones. The expulsion of the placenta results in dramatic decreases of placental produced hormones. So the decreases in the chorionic somatotropin, mammatropin, estrogens, cortisol, and placental enzymes reverse the effects of pregnancy. So estrogen and progesterone levels will drop markedly, and metabolic changes will begin. The pituitary hormones and the ovarian function. So the lactating and non-lactating woman, it will differ in timing of the first ovulation and menstruation. 70% of non-breastfeeding women will start to menstruate about 12 weeks after birth. And if breastfeeding, they'll return to ovulation depends on their breastfeeding patterns. In non-lactating women, ovulation can occur as early as 27 days after birth. Uterine components. So the urinary system includes the uterine components. The fluid loss within the 12 hours, women begin to diurese. So all the fluid that is given to the patient with the IV fluid and the extra fluid that she holds on to with being swallowed during pregnancy will start to diurese within 12 hours will start to begin. So profuse diuresis often occurs at night for the first 2 to 3 days. So this patient may also have to get up and urinate a little more often. So urethra and bladder, excessive bleeding can occur because of the displacement of the uterus if the bladder is full. So if you go into a room and you're checking a fundus and the patient has a lot of bleeding and her bladder is over to the right or the left and not midline like it should be, then you ask her to get up and go to the restroom and make sure that she continues to get up and allow herself to urinate every couple hours, just so that she can continue to have that uterus stay tight and not have the bladder kind of push or displace the uterus, which can cause more bleeding. Breastfeeding mothers, before lactation, a yellowish fluid called colostrum can be expressed from the nipples. Colostrum is like baby gold. Colostrum is very important. It happens within the first 24 to, it's about 20, it can happen a little bit before birth. It starts, well, you want to make sure that the baby gets the colostrum. That gives it enough nutrients to suffice until the breast milk comes in. So it's very nutrient dense and very important. So when a mother is thinking her baby's not getting enough food because she's trying to breastfeed every 2 to 3 hours, but there's not much coming out, that colostrum is very full of nutrients. Breasts become fuller and heavier, and estimate when the breast milk comes in could be 72 to 96 hours after birth. We always tell them at least 3 days, 2 to 3 days. Non-breastfeeding mothers, engorgement resolves spontaneously and discomfort can decrease within 24 to 36 hours. For the cardiovascular system, the blood volume changes. It depends on several factors, including blood loss during childbirth, the amount of extravascular water mobilized and excreted, and pregnancy-induced hypovolemia may allow most women to tolerate the blood loss during childbirth. Cardiac output. You want to be aware of their vital signs. Make sure that vital signs are usually taken every 4 hours on a patient that's had a C-section for the first 24 hours. And usually we do that for the vaginal births as well. Sometimes we can switch that to 8 hours, depending on the hospital policy. So blood components, hematocrit and hemoglobin are checked the next day. White blood cell counts are checked, and if needed, the coagulation factors are checked. Varicosities. Our total or nearly total regression of varicosities is expected after childbirth. Chlasma of pregnancy usually disappears at the end of pregnancy. That's the brown spots that may appear on the face that persist in 30% of women. Hyperpigmentation of the areola and linea nigra may not regress completely after birth. So the darker areolas and the line that appears from the umbilicus down may not regress completely after childbirth. So some women will have permanent darker pigmentation of those areas. Stretch marks on breast, abdomen, and thighs may fade but do not disappear. Vascular abnormalities like spider angiomas, palmar erythema regress with rapid decline in estrogen levels. Spider nevi persist indefinitely for some, and hair growth slows during the afterbirth period. Some women may experience significant hair loss. The immune system, so mildly suppressed during pregnancy, the immune system returns to its pre-pregnancy state. Rebound of immune state can cause flare-ups of such conditions such as lupus or MS. Chapter 19, Nursing Care of the Family during the postpartum period. So components of nursing care include assisting the mother with rest and recovery after birth. You want to let the mother know, at least in the hospital, to rest when the baby rests, sleep when the baby sleeps. Assessment of physiologic and psychological adaptation will occur at this time. Prevention of complications, education regarding self-management and infant care is important to help the mother feel comfortable when she leaves the hospital. She's still going to have questions. She's still going to feel she wants to make sure she's doing everything right. So support the mother and her partner during this transition to parenthood. Always be available, kind, and answer their questions. If you don't know the answers to the questions, make sure you get them and go back to the patient and try to give them as much information and education with self-management and infant care as you can. Feeding the baby every 2 to 3 hours. If it's breastfed, you want to make sure the mother knows that she needs to actually wake up the baby. Even if the baby's sleeping, the baby needs to eat every 2 to 3 hours. As they get older, it's really feed on demand. But when they're so young and so little, you want to decrease the incidence of jaundice and make sure they're having enough urines and stools. So you want to make sure you feed them every 2 to 3 hours. If breastfeeding, it's like 3 to 4. It's a little bit, you can stretch that a little bit if they're fed with bottle feeding. They'll have a little paper that they want to write down when they started feeding, when they stopped feeding, if breastfeeding, when they started feeding, how much they actually fed the baby, if they're bottle feeding, and then you want to make sure they write down the stools and the urines that the baby has. In a traditional setting, the woman is moved to a postpartum recovery room. The LDRP, so labor, delivery, recovery, and postpartum setting, the woman and infant remain in the same room while where they birthed. Some hospitals, they'll have a birthing area and the labor and delivery area, and then they'll have a postpartum area. Post-anesthesia recovery, regardless of the obstetric status, no woman should be discharged from recovery after the recovery area until completely recovered from anesthesia. So we check dermatomes. We check how where the woman is numb at, and if she's starting to get the feeling in her toes, and we want to make sure that she's actually starting to get all that feeling back before we are able to go over to the postpartum period. We usually stay post anesthesia, we usually stay 2 hours if they have had a C-section, so it'll be every 15 minutes for the first hour and then every 30 minutes on the second hour. This depends on the policy at the hospital, so it depends on, you want to make sure you're up to date with hospital policy for your unit. Length of stay is dependent upon the physical condition of the mother and the newborn, the mental and emotional status of the mother, the social support at home, educational needs and for self-management, and any financial constraints. So if the mother's not adapting with the baby, there may be raised some concerns of, is the baby going to have the support it needs when it goes home with the mother? Mom wants to be not bleeding much, and vital signs are good, no fevers, anything like that, no infection, and she should be good to go. Baby's testing will depend on if baby's allowed to go. They'll check the baby's jaundice levels. If the jaundice is too high, it may need to be put under the billy lights, or they may just need to make sure the baby's fed enough and urinated and defecated enough to remove that and to bring that number down so that the baby can go home. Also depends on when the baby was born. Is the baby preterm? Is it late preterm? Is it term? So newborns and mothers, the Health Protection Act of 1996 allows for a minimum of 48 hours stay after vaginal birth. So they're usually there 2 days and 3 days for a C-section. Now, if the mother is doing much better, sometimes the doctors, or she's had a C-section before, she's up and moving, the doctors may let her go home at the 48 hours. And with the vaginal births, in some of the parents want a 24-hour discharge. They cannot leave any earlier than 24 hours. If they want a 24-hour discharge, it's usually a midwifery center, and as long as all their testing comes back okay with the baby, then they're usually able to go. The criteria for discharge is recommendations occur from the American Academy of Pediatrics. Ongoing physical assessment will continue throughout the whole stay. Routine lab test, so an H&H will be drawn the day after delivery to make sure the mother didn't lose too much blood. Nursing intervention, so preventing excessive bleeding. Make sure that the patient is maintaining a uterine tone, preventing bladder distension. So you want to make sure that she's getting up, she's going to the restroom, she's not waiting 8 hours to urinate. Preventing infection is important, and promoting comfort. So non-pharmacological interventions, and sometimes pharmacological interventions are needed for pain. Here's an idea of how you're holding the uterus and touching the top of the uterus to find out how far the fundus is, and if it's firm, it's midline, and it's appropriate, it's not bulgy. It should feel, right after birth, the fundus almost feels like a softball, literally like a ball. So nursing interventions continued. You want to promote rest, want to promote ambulation, getting up and moving, promote exercise, promote nutrition, promote normal bowel and bladder patterns, bladder function, bowel function, promote breastfeeding, very important, and lactation suppression if needed. Most hospitals have a lactation consultant if patients are needing assistance with breastfeeding. The nurse can help as well, but there's also usually a lactation consultant that goes around to the patient's room to give them some more tips, give them information on local support groups, as well as their number to call if they need any information about lactating. Health promotion for future pregnancies. So keeping up to date on vaccines, rubella, varicella, Tdap, and the ROGAM administration if needed. So care management, psychosocial needs, the effect of the birth experience. Some people feel that they've had a traumatic birth experience. Some people may need some counseling, depending on, they can feel kind of let down if they brought in a 2-page birth plan and it didn't go as they planned, or they had to have a C-section and they wanted to have a natural birth. So being aware of the maternal self-image, the adaptation to parenthood, and parent-infant interactions. This is done while you're doing your rounds. Care management, psychosocial needs, family structure and functioning, effects of the cultural beliefs and practices. There are some patients that their culture believes in eating the placenta right after delivery. So we've had little crock pots that have showed up in the room that they've cooked the placenta to make sure they eat the placenta. There's a lot of different cultural beliefs and practices, and you want to just be open to the differences, and if they need a spoon, you go get it for them. So discharge teaching, self-care, and signs of complications. You're going to tell the mother to make sure, no heavy bleeding, no heavy clotting, larger than the size of a, could be a little, pretty much like a softball. You don't want to have a large clot like that. You don't want to go through a pad an hour, any of those kind of complications. Fevers, really foul discharge. You want to make sure she contacts the doctor for the baby if the temperature is over 100.4. There's a whole list of things to make sure that you give the mother when she discharges, to be aware of any complications and when to seek care. Sexual activity and contraception, that'll be discussed with the midwife or the provider with the patient. You may have to also let them know, like, no douching, no this, no that, if they've had a C-section, and then also discharge teaching on medications. Here's mom and dad adapting with baby. Follow-up after discharge will include routine scheduled care. Sometimes there's home visits, telephone follow-up care, there's nurse lines, support groups, and referrals to community resources as needed. Chapter 20, Transition to Parenthood. So the period of change and instability for all men and women. Adoptive or biologic parents. There could be married or single parents, lesbian or gay parents. Parenting is a process of role transition. So it requires cognitive, affective, and motor skills. Infants' well-being and development depends on these components. The process begins with attachment, bonding, proximity, interaction, so mutuality, acquaintances, and claiming process. Here's mom bonding with a very young baby with oxygen. There's mom bonding with another baby. Assessments of attachment behaviors, so careful observation of specific behaviors, formation of emotional bonds, so skillful observation and intervening. Enhancement of parent-infant contact by increasing the parent's awareness of the infant's responses. Now, hospital rooms are set up with rooming in, so they take care of, it's called couplet care, where they take care of the mother and the baby in the same room instead of taking the baby to the nursery. Now, there may be instances that the baby's in the nursery for testing. If the mom's had a C-section, the mother can't be left alone with the baby because she can't jump up if the baby starts to choke or needs help. So the baby's usually in the nursery. Other than that, the hospitals now have adapted to rooming in and wanting the baby to be in the room as much as possible with the mother. Early contact may facilitate attachment processes, and skin-to-skin immediately after birth is proven to help with that attachment process. Extended contact, optimizing family-centered care, and achieved through couplet care, as we talked about. The baby is in the room with the mother the entire time. Family is encouraged to participate in the care. Communication between the parent and the infant. It's done through senses, touch, eye contact, voice, odor, entrainment, biorhythmicity, and reciprocity or synchrony. Parental role after childbirth, so the transition to parenthood, the parental tasks and responsibilities, becoming a mother, dependent behavior, dependent independent behavior, and after birth blues. To be careful about the change in the hormones can cause some depression or baby blues, but when to seek help. You want to make sure you know when to seek help. If the mother is experiencing more, anytime she has any kind of baby blues or depression, it's important to talk with the healthcare provider. That is actually screened at the baby's first visit with the pediatrician as well as the postpartum visit. So becoming a father, father-infant relationships, engrossment, adjustment for the couple. There'll be some adjustment for the couple. Resuming their sexual intimacy is important. And infant-parent adjustment, so rhythm, behavioral repertories, and responsivity. Here's dad holding baby. Baby looks like he has an NG tube. It's a young baby. Here's mom interacting with baby. So diversity and transitions to parenthood. Age, so the adolescent mother, adolescent father, maternal age older than 35 years old, and paternal age older than 35 years old. Parenting with same-sex couples. Diversity and transitions to parenthood. You want to make sure that they have the social support, be aware of the culture or any kind of cultural beliefs that you can help with, socioeconomic conditions, personal aspirations. Visually impaired parent does not have negative effect on parenting. The heightened sensitivity to other sensory outputs. Skepticism by healthcare professionals. There should not be any. Infant will need sensory input from the other parent. Hearing impaired parent, so the mother or parent establish an independent household. Technological devices aid in parenting, and young children acquire sign language readily. Sibling adaptation, have to assume new positions within the family hierarchy. Reactions manifest in behavioral changes. You may have outbursts, or the sibling may adapt well. Involvement in planning and care is important, and acquaintance behaviors. Grandparent adaptation, most often associated with joy, may feel regret due to poor health or geographic distance. Grandparents are eager to help, so maternal grandmother is called on the most. Intergenerational relationships may shift in involvement of dependent or cultural and family factors. Nursing care directed toward helping the parents cope with the infant care. The role changes, the altered lifestyle, the change in family structure due to a new baby, and any anticipatory guidance. Postpartum complications. So afterbirth hemorrhage is a postpartum complication. Its definition and incidence is the leading cause of maternal death worldwide, and postpartum hemorrhage traditionally defines as a loss of more than 500 mLs of blood after a vaginal birth, which is pretty much half of a bag of IV fluid, and 1,000 mLs after C-section. That's one bag. The etiology and risk factors, so uterine atony, retained placenta, lacerations of the genital tract, hematomas, and an inversion of the uterus. Care management includes assessment, medical management if needed, surgical management if needed, and nursing interventions. Here's a picture of some of the placenta that is retained. It's showing how the blood can easily fill up in the uterus. Uncontracted uterus, so the uterus is not contracted down, it just continues to fill with blood. And then you have the blood from the severed vessel of the placenta, and it's slowly trickling out of the uterus. When you go to check that fundus, you notice that that fundus is way above the umbilicus. The umbilicus, let's see if I can put it here. The umbilicus is about here. So when you go to check that fundus, it's way higher than it should be. You go to massage that fundus, and that blood is going to come right out. You're going to want to continue to massage that fundus to keep it hard, and then initiate IV fluid, a catheter to keep the bladder not distended. There's a whole set of policies at your unit. So cancer management includes management of IV access and blood products if needed. If it's a hemorrhagic hypovolemic shock, nursing interventions is Foley, oxygen, vital signs not to adjust, may not adjust until 30 to 40% of blood is lost, so vital signs might not be very different yet. Coagulopathies, so idiopathic thrombocytopenic purpura or von Willebrand's disease is a type of hemophilia that could be reasons due to the hemorrhage. Venous thromboembolic disease results from blood clot caused by an inflammation or partial obstruction of the vessel. Afterbirth infections can include endometriosis, wound infections, urinary tract infections, because Foleys are placed often. Mastitis, what is it? It's showing the clogged milk duct, the inflamed breast tissue. Afterbirth mood disorders, so afterbirth depression. Parental afterbirth depression is assessed for the maternal and the paternal, and you want to be well aware of afterbirth psychosis and the partner to be aware of the signs to call for help. Other afterbirth mood disorders could include afterbirth anxiety disorders, bipolar disorder, and that concludes 18, 19, 20, and 21. Have a good night.